healthcare. But for the sake of this context, it's the community level and the lower level facilities, which are the level 2 and 3. And this one, we are saying that the commitment by the government is that it will be publicly financed. And we have seen those initiatives through payment of community health promoters. For the first time, community health promoters are being paid a stipend by national government, and of course, having a matching fund, a matching amount at county level. The government has also invested in the community health kits and also the gadgets, the phones to collect the data. So all this is publicly financed. When you look at the level 2 and 3, and as we go into the social health authority bit, we'll see that the primary health care fund within the social health authority is actually mainly to procure services at the lower levels, which is the level 2 and 3. And the main source of these funds is once again publicly financed, meaning that it's not contributory. When you go to the middle part of the pyramid, we have the social health insurance, which we know is contributory as it is by both the formal and informal sector. And the Social Health Insurance Act provides that this particular fund, actually contributions will be mandatory for the country, for all citizens and residents in Kenya. And we all know the amount, which is 2.75% of one's income. Then we have the Emergency Chronic and Critical Illness Fund, also for level 4 to 6, which is a smaller component of the greater pyramid. So basically, when you're talking about health financing, a sustainability shift, this is what we want to shift from. We want to shift from voluntary contributions, which were there before under NHIF. They were more or less voluntary. That's why only 25% of the population were covered. And we want to move to compulsory. And the reason why we want to move to compulsory is we want to have a bigger base. We want to have more people cross-subsidizing, so that it's not only the sick people who are in the pool. We have a mixture of those who are sick. So for those who are sick, they are paid for by those who are well, and those who are young and at a lower risk are paid for those who are old and maybe unable to contribute or sick. And that way, so we are moving from voluntary to compulsory. That is one of the sustainability shifts. We also want to move from out-of-pocket payments to having a prepayment mechanism, because we know that at times you never know when anyone will fall sick. And if you depend on out-of-pocket payment, it means that you may fall sick at a time when you actually don't have the resources, and therefore that will push you further into poverty and probably also your relatives into poverty. Therefore, within this shift, we are saying we also want to move from out-of-pocket payment to prepayments. And we also want to move away from externally, depending on external financing, to having domestic financing. Of course, in all these cases, we cannot totally eliminate. We can't be 100% perfect. We can't say that will be 100% compulsory, but then our target as it is for now is 85% compulsory. So in terms of what are the ways in which we have tried to address this issue of sustainability, especially knowing that Kenya has moved from a low-income country to a lower middle-income country. That means even the external resources that we used to receive in form of grants now come in form of loans. And that's one key thing that really impacts countries when they move from low-income country to low, middle, and middle-income countries. You are said to have more muscle, and therefore, yes, you may get external aid, but it won't come as a grant. It will more or less come as loans. Then in terms of, when you look at the overall official development assistance to Kenya, 30% of that is actually comes to the health sector. Within the health sector, once we get that 30% of overall ODA, official development assistance in the country, a good proportion of it actually more or less more than half of the funding for HIV, TB, and immunization actually comes from external financing, which is quite risky. 20% for malaria and 16% for reproductive health. So we can see how uh, how much we are dependent and which conditions are mainly dependent on donors. And therefore, when you talk about the donor dependency ratio, like for immunization, for every shilling that, or for every dollar that the government puts in, there's a dependency of $3.3 from the donors. For immunization, around 2.8 for TB and 1.7 for HIV. So I think that should be a wake-up call that as we think of shifting towards domestic resource mobilization, then how do we gradually move? It can't be something that we will decide overnight and shift. It has to be a gradual move. This is just around why do we really need to have the donor, more or less the donor transition, and it's to avoid the dependency and concentration. Kenya is said to not only be dependent, but also have donor concentration. In the sense, for donor dependency, it means that the country is unlikely to have the capacity to fill that funding gap of the donors in one go. And then when you look at donor concentration is where there are a few donors who make up the large amount of the overall donor resources. And like in Kenya, we have around 4 main donors who actually support health. Of course, the United States Global Fund, the UK and Gavi, which make up around 90% of all health ODA. And that's what I mean when I talk about donor concentration. So if we are to move towards domestic resource mobilization, we have to look at how can we increase our physical space within health. And by increasing the physical space for health, there are these 5 main areas that we have to look at very keenly. So we have the macroeconomic conditions. We all know right now that as a country, a good proportion of our resources go towards payment of debt. For every 10 shillings we have, 7 shillings go towards payment of debt. So the 3 shillings are the one we have to see how to divide amongst the different sectors. So already when we are tied up there, then it becomes very difficult to further increase the physical space. Then when it comes to reprioritization, even within that 3 shilling that we have, we can still get more of the resources. And that's where reprioritization comes in. Then sector-specific revenues. And within the sector, we should be able to raise revenues either through engagement with even the private sector, looking at how can we bring on board different players so that we can increase our revenues and therefore increase our physical space. Then, of course, the other way of increasing physical space is through efficiency gains. And this is one area that really looks around matters to do with avoidance of wastage, seeing how we can put avoidance of duplication and all that. So these are key areas. So I won't really touch on that. I won't touch on that. But in terms of efficiency, just allow me a minute to touch on this, because when you look at efficiency, you're either looking at cost containment, that you want to reduce the waste within the system, and of course think of how do you purchase things, say through where you can have economies of scale, even in purchase of services, and therefore reducing wastage within the system. And of course, then the other way is around looking at improving access to necessary services. So efficiency alone is one way in which we can achieve increased physical space, because we have seen the macroeconomic conditions and the reprioritization may not really change much, because it seems like it's a something fixed. So many times during budgeting, Treasury tell you that this is your ceiling, and therefore you just have to work around that ceiling. So within that ceiling, then how do you increase even more fiscal space? And this really looks around efficiency. And that's the premise in which the Social Health Insurance Act was actually drafted, so that we see how can we increase our efficiency, how can we bring in issues of integration, bring in these three funds together, so that we are able to purchase services in a more strategic manner. So talking of which, we have this, we all know the four main acts that were passed, that were enacted towards UHC, and currently we have one being drafted on quality of care. We have a draft quality of care bill. So we have the PHC Act, Social Health Insurance Act, Digital Health Act, and the Facility Improvement Financing Act. So just looking at probably, we also have the social health insurance regulations that now provide the how the act is meant to be implemented. And within the act, we know we have the three funds: the primary healthcare fund, the social health insurance fund, and the emergency chronic and critical illness fund. So how have HIV services been integrated in these health financing reforms for a more sustainable financing? If you look at the primary healthcare fund, we are saying that this fund, first of all, will be publicly financed, as I indicated, and it will purchase services from primary health care facilities. And here we are looking at level 2, level 3, and probably a select level 4, where we don't have say a level 2 or a level 3 nearby. So we are also allowing for that. And when we are purchasing these services, we are not restricting it to any disease condition. We are saying that any patient who walks into a primary level facility should be able to receive whatever service they require at that level. And this also includes, it mainly includes preventive, promotive, basic curative, rehabilitative, and rehabilitative care at that level. And therefore, in terms of integration, as we think of service level integration from the vertical programs, and specifically in this case, HIV, we already have a system in place. So even if you need to do the service level integration, instead of having the standalone clinics, then these patients can still be seen at primary care level, and whatever service they need will be provided to them. Then, because so here, this just highlights the benefits within the primary healthcare fund: health education and wellness, counseling, consultation, diagnosis and treatment, some laboratory investigations, radiological investigations, and management of, finally down here, management of NCDs, enteric infections, neglected tropical diseases, STIs, HIV. They are all catered for at that level. And also issues to do with screening, especially we know that people living with HIV could have a higher risk when it comes to cervical, for instance, cervical cancer screening. We have also catered for that at that level, and even early management of the cervical cancer through either thermoablation, cryotherapy, and LEAP at that level, so long as the staff are trained and they are fully equipped to offer that service. And this also includes minor surgical procedures and medical procedures, such as male circumcision. We are also catering for that at the PHC level. And the others are around maternity, newborn, child health services. Those ones continue at that level of primary health care, including family planning, deliveries, maternal, neonatal, and child health care. I think this one I talked about the screening, both for prostate and basically the four top cancers in the country. So just moving quickly to the social health insurance fund, we are saying that this one, first of all, you have to be a registered, you have to be a registered and paid up member to enjoy the services of the social health insurance fund. And this one we are saying the services will start from level 4 to level 6. And of course, there'll be the contributions. And for those who are unable to contribute, the indigents, the vulnerable persons, then these ones will be, the resources for this population will be appropriated by the National Assembly. Now, in terms of registration, we know that we have been really working hard to get people on board, the SHA. So this is just one way of registering. Registration could happen in many ways, including self-registration on phone. You can also use the browser and also be registered at different physical centers. So if anyone would like to register, we have this *147#, and through registration, you'll be able to add your dependents, if it's your spouse and your children, in the process. The other way of registering is through the browser. You can say afyayangu.go.ke, afyayangu, or www.sha.go.ke. You should be able to register. And as you register, if you are in the informal sector, you are given the opportunity to go through the means testing, questions that are relevant to determine how much your premium will be. It won't be like previously where for the informal sector, they were paying 500, but now we are saying that based on the questions that you answer, you'll actually be, if you do that, you'll be able to get to know how much your premium is at the end of the registration. And for the informal sector, the law provides for them to pay on an annual basis. And this is just because of the logistics of, getting hold of the informal sector. It can be a bit difficult, but then we are saying that there'll also be, for those who are not able to have the resources immediately, there'll be opportunities from what we say premium financing. So this could be either from cooperatives, from banks, and we have seen quite a number of banks having an interest in providing premium financing. And even next week, there'll be a premium financing symposium where we are bringing in most of the financiers who will be able to give the members, say, loans, with a very small repayment to pay for their health insurance. And then as people get resources, they can pay up over the year, but at least by then they'll be covered. This one I talked about this, that the contributions from salaried employers, from salaried employment will be at 2.75%, and will have to be submitted by the 9th of each month, and it shall not be less than 300. But for the unsalaried, basically those in the informal sector, the payments will be annual, and they'll have to be done 14 days before the lapse of the next premium. We'll still continue catering, as I said, for those who are in need of financial assistance. I know this is a question that many counties really ask about. What will happen to our indigents, the ones who are identified? They'll have to re-register and undergo the means testing. Once they do the means testing, if it's clear that they are still indigents, because I don't want to be the devil's advocate, but we have had a number of complaints that some people even, uh, uh, have been indigents, have been classified as indigents when indeed they are not really indigents. So through the means testing instruments, if the existing indigents will actually be found to still be indigents, then there'll be the resources to cater for them. Uh, uh, the law also provides for those in lawful custody, basically the prisoners. We all know that the prisoners who come to our facilities are usually more or less treated for free. But then this time we also want the correctional services to be able to cater for these prisoners, so that when they come to the facilities, they should be able at least to have a form of a prepayment. For the people above the age of 25, I know this was a controversial discussion. It was a controversial discussion. These are the Gen Zs who are now on the streets, and we are saying that if you are above 25, the age of 25, below 25, if you are in school, then you are still a dependent. But after 25, then we are saying we'll also do a means testing, and depending on whatever we'll find, then you will have to also contribute. The scope within the social health insurance fund, I just want to, I don't want to go through each and every of the scope, but basically I would just say in overall, in the outpatient, the same scope as the primary healthcare, but in this case, we are looking at uh, people who at least have been referred, because that means they are coming to seek specialized care. Specialized care. And for this, since we are paying per visit, unlike the other one where we were paying more or less in form of quotation, then we are limiting this visit to 4 per person per year, so that there is no real motivation to keep just either from the patient or from the provider to keep seeing patients so that they can make more money. But then if
Dr.
there are, of course,
Wangiek,
special. Yes,
kindly
please.
kindly wrap up.
Okay, yeah. Yes, thank you. So I think, so basically that should be it. Uh, so the cover will be, basically we have almost 18 packages. We have the renal package, we have the mental wellness package, the surgical package, oncology package, imaging, specialized laboratory, pharmacy, critical illness, and palliative care services. uh, uh, for once, we'll also cater for emergency services, um, which was previously not there, and this is pre-hospital and also hospital emergencies. Now, yeah, so I think that should be it. There's this slide that I just wanted to wind up with. Actually, I was even finishing just with that. Where exactly does the social health authority or social health insurance fit together with the vertically financed programs? And here we are saying that the benefit package is quite comprehensive, and therefore it will cater for the management of most of these conditions. Even when you look specifically also at opportunistic infections, then the other thing is that currently, we know that most of the programs, and specifically even the HIV, for the next 2 years, we know their level of financing, and since the package will be reviewed every 2 years, then there'll be an opportunity in between to build a case in case for the next cycle of the benefit package, and we're really hoping that by then, depending on the availability of resources, we can expand the cover better to cater for even some HIV specific interventions. So I think I'll stop at that session, Chair. Sorry for going way overboard, but I thought it was also quite key to pass the message. Thank you.
Thank you, Dr. Wangia. Let's clap for her. Daktari, please stay on. We are going to have a session which is plenary, a panel discussion, and will require your presence to answer a few questions that may arise. So, ladies and gentlemen, we would like now to move towards wrapping up, and to help us do that, we have constituted a panel of very eminent persons who are going to come up here to give us their closing remarks on very specific areas in their jurisdiction. To help us do that, I would like first of all to call Brian Redman to come up here and take his seat. He will be speaking on behalf of the US government. Thank you very much. Next is the chair of the CECs from the counties. Dr. Michael is not here, but I think it's represented by Dr. Roslyn from Homa Bay County. Let's clap for her. Next to come on stage, I would like to call my good friend Joseph from Equity Bank to represent the private sector to come up to the podium. Let's clap for him. This conversation is not complete without the voices of the community, and therefore I would like to call two persons, one representing the young people, Rosemary Njeri, and Patricia Osero. Last but not least, I would like to request my good friend, Dr. Wako Erjesa, to come and give us a few insights on the plans for Global Fund to build resilient and sustainable health systems. Let's welcome him. Last but not least, I would like to take this very special moment to invite the chair of the Parliamentary Health Committee for Health, Dr. Robert Bukose, whom I would like to request to introduce his team first, then take the seat also to respond to very critical question. Karibu.
Okay, thank you. Thank you, Dr. Sirengo. Good afternoon. My colleagues, the members of parliament, we have the Minister of Health being represented here by Mr. Rugaria, the head of NASCOP, CECs of health from various counties, together with various heads of the delegations, our partners who are here. My names are Dr. Robert Bukose, Member of Parliament Endebess, and the Chair of the Health Committee in the Kenya National Assembly. With me are my colleagues, and I'll just mention them and ask them to stand. Professor Guyo Jaldesa, member for Moyale. He's a professor of gynecology, still practicing. Honorable Martin Pepela, member for Webuye East. I think he's a herbalist. Honorable Mary Maingi, member for Mwea. I would say she's a house, midwife. Honorable Joshua Oron, member for Kisumu Town. And I think those shouting, they know that he has other interests. He tells me he wants to be the governor for Kisumu when Professor Nyang' Nyong'o leaves. So I wish him all the best. We also are accompanied by our clerk, Hassan Orale. Where are you? I think he's somewhere. So I was asked to introduce my colleagues. And then I think that is it, Orengo. Nani, Sirengo. Sirengo and Orengo are the same. In Luya, it is Sirengo. In Luo, it is Orengo. I don't know in other places. So allow me to join them, then I'll be able to respond to the various issues that maybe we'll be able to listen to you. But I could just say one thing that Dr. Wandia talked about in terms of health financing and issues about budgeting. The Committee of Health, we are involved in budgeting for the Ministry of Health, and the Parliament in general involved in appropriation, that is budgeting, legislation, oversight, and representation. In the past, since independence up to when we got the new constitution, 2010, the ministers used to sit in parliament. And the minister for finance would come with a huge document to make budgetary representations. During that time, that document has a budget, it has the finance bill inside, it has the appropriation, and also supplies. I know people might not understand some of these things. So after reading the budget, that midnight, the prices of unga will rise, the price of cigarettes will rise, the price of alcohol will rise by a certain percentage. And that's what used to happen in the past. When we got our new constitution, things changed. Parliament now became a budget-making body. As a budget-making body, budget begins with the estimates being done from various stakeholders. Then the Cabinet Secretary for Treasury lays what we call budget policy statement. In budget policy statement now, you set up the ceilings per ministry, per line item. Once that is done and it has been discussed, all the ministries come, the departments come and make their presentations. Once that is done, then we wait for the Cabinet Secretary to table the budget. Then this budget now comes, we approve, we go through it, we discuss with the various departments, MDS, the ministries. Then after that, Parliament now discusses and approves. That is where you now say we are going to put, every constituency will get 30 million for electricity. Every constituency will get 50 million into their CDF. We are going to put this much for the roads. We are going to put this much to the Ministry of Health. And we come down with the programs. Once that is done, we, as Parliament, we approve. And at that time, there was no voting against it. Everybody accepted and said, yes, I want 30 million for my constituency for electricity. I want 50 million for my constituency for roads. I want this for CDF, and we accept it. That is what happens in Parliament. Now, because things have changed, the next thing that is going to be laid is how do we raise that money? Yeah? How are we going to raise that money? Now, that is where the finance bill comes in. And before the finance bill is, then it is laid it is stapled in the House, so it goes through public participation. While it is going through public participation, the Cabinet Secretary for Treasury comes to the House and tables the budget that we are going to give counties 400 billion. We are going to give this ministry this much. We are going to, for those programs which Parliament budget has put, this is what we are going to do. Then during this public participation now, you have issues where people say, no, we can't raise the price of unga, we can't raise the price of bread, yeah? We can't raise the 2.5% for the vehicles. Then we listen to the public. Once we've listened to the public, the bill comes to the House for debate. That is what happened yesterday. So we debate. After debating, even our colleagues who had passed the budget and accepted that they want 30 million for their CDF, they want 50 million for that, because now people are saying you should not put these taxes. You say now this should not happen. Yeah? So we passed the second bill, that second reading. 205, 204 against 115. That is where politics now starts. After that, next week we'll be doing the third reading. That is where we'll be bringing amendments. We listen to the public said don't put the 2.5 for the vehicles. Remove the VAT for bread, which we are going to remove. We are removing the 2.5. The sanitary towels, we are saying we don't want those ones which are imported. They should be taxed, but the ones which are made locally should be tax-free. That is the debate. Okay? And that is where we are going to get the money to finance healthcare. And the debate continues. Thank you.
Thank you, Honorable Pukose, for your submissions. I think you read the mood of the room. You needed to say something about the finance bill. Yes, so now we can continue with other business. Yeah, so ladies and gentlemen, apologies, I think I forgot to call Dr. Mwangi from ECPAF to join us, please, up here. I have a very important question for you. So to start us off in this discourse, you know, we are in the dispensation for bottom-up. So I would like to start with the communities that we serve. Sorry. So I would like to start with Patricia. Patricia, you gave us here a presentation about your thoughts on integration. But as we close this summit, what do you think are the main gains in this discussion of integration that people living with HIV are going to benefit as we begin this journey? Karibu.
Thank you, Dr. Sirengo. Allow me to say my worries, Daktari. Because when we are talking about integration, I did raise a number of issues, and even during the discussions, nobody was really able to answer my questions. And Dr. Elizabeth has even made me more worried as she made that submission about chronic illnesses, that one is only allowed to go to the facility 4 times a year. As a person living with HIV, that is quite worrisome because we are also aging with HIV. As I stated the other day, like right now, I have a swollen feet. This is how swollen it is. I've been undergoing treatment for a while. So if I was getting access to SHIF, then only the treatment for my feet, I would not be able to access treatment. So that one is quite a concern. So if that is what integration could be, then that is something that would not benefit us in any way, as person living with HIV and also aging with HIV and living with NCDs. That will not work for us. That's a concern. The second concern is the workload. The Ministry of Health and NASCOP specifically has come up with a system called differentiated service delivery. And that was to offload the health facility so that those people who are stable could be able to pick their drugs either from groups or from the community or just going to the pharmacy to pick their medication, so that the ones who have advanced HIV can now be seen in the facility. But when you integrate the services, then there's going to be a big concern in that area in terms of workload for the staff. Let me give an example of a clinic called Ligala where I went to do community CLM. We went to see how things work in that facility. And there was just one nurse. She's the midwife, she's the doctor, she's the pharmacist, she's the everything. Just one nurse giving services in that facility. The person who was assisting was the one who was running the HIV clinic. So if today we integrate, that means the person who is running the HIV clinic, because it's a partner supported, will not be there. It will be the nurse. What kind of services will we be getting? Because even now, there are some facilities that I said on Tuesday, I'm repeating now, that people are being seen by peers. People are being seen by CHPs. CHPs are not trained to see a person who is taking antiretroviral medication, who has complications with their organs because of the side effects of the medication, and who is also on anti-hypertensive drugs and also has diabetes. So those are some of my concerns as we think integration. When you talk about a human resource, is this human resource just CHPs? Because that is what I've heard Elizabeth talk about, that they've equipped CHPs. They've given them some equipment. So when we're looking about care, we are not just thinking care, we want quality care. It's about access, it's about affordability, and it's about quality. That is what I'm looking at. So I would say that if the government is thinking about integration, then they are supposed to invest. They are supposed to invest. They are supposed to put their money where the mouth is. Yeah? You cannot tell me that my child who is 25 years and not working is going to be charged some amount of money. That is why they are out in the streets. Yeah? I've taken that child to school. They are qualified, but there are no jobs. Then you are coming down again to stress them with some payment, and I'm already also being paid down, being stressed with the payment. So those are the major concerns when it comes to integration. Otherwise, integration would work well if the government would invest in it, if the clinicians would be trained, if we would have qualified clinicians. We saw clinicians on strike recently, and we know we have quite a number who are not employed. If these clinicians can be taken into facilities, and the idea that a professor told us, that students can also be integrated so that they will be working maybe 2-3 months in a facility to improve the services they give back to the community as they also gain experience. So we need to see how best we are able to integrate our services, and we start slowly. You cannot do everything at once. If you say we are starting with non-communicable diseases, then we start there. Then maybe, because we have already integrated TB, which is working, So maybe we go non-communicable diseases, then maybe later on sexual reproductive health, then bit by bit and see how it works out. We cannot roll it out at once. Otherwise, the gains that have been made will be lost along the way.
Thank you very much. Very powerful. All the decision makers are in this room. I'm sure they're taking notes. And your concerns are well noted. So to just help us complete the expectations and concerns, let's hear from the young people. Rosemary, you've been here from Tuesday. What are your closing remarks? What are your expectations? What are your worries about this discussion for integration?
Okay, thank you so much. First of all, I'd like to appreciate the opportunity that young people have been given so far. And this is all in efforts through even the government and the different donors in our spaces. So we appreciate you. Thank you for giving us an opportunity and that chance. When I look at integration, I'm looking at it as many of the young people had said here yesterday, that we're looking at a one-stop shop for almost all our services. So when I look at integration, we have some drop-in centers that are supported by different partners and are really working well. So when I look at access to services for young people and our integration and the holistic approach of the same, I'm looking at a youth-friendly environment that would be able to give services to young people, in which case most of which was showcased here throughout the week. And we thank you all for some of the researches that you've done in the same. But my greatest story, as Ms. Patricia has also echoed here, would be that probably we'd lose out on the quality of care when it comes to integration. So I'd urge you, as you're looking at integrating the services, you also look at the impact that it would bring to us as young people. So if you're talking about quality of care, we don't want it to be lost, where we have fragmented care. As much as we're entering into those services, we don't have people who are friendly enough to cater for all our needs. Another worry for me would be the resource constraints. As you can see, for us young people, we're out here, we're doing quite a lot with ourselves, trying to hustle, trying to get resources to even facilitate our different movements and our sustainability in life in general. When I look at that, I'm also looking at a way of ensuring that we are also not so burdened with the resource constraint on this other side. So if it's possible to also look at that aspect. Other than that, also in terms of the database management system, okay, when I see the integration of services, I'm also trying to see how best we'd ensure that confidentiality is put in place, considering, you know, as much as we're trying to improve and incorporate all services in one center, we'd also try our best to ensure that we have confidentiality of the same, because that's also what young people are looking towards. So majorly under resource constraints and data management for the same. Yeah, thank you so much.
Thank you very much. Now, we've heard about the concerns of adults. Heard about the concerns of the young people. There's one important constituency who are not in this room: children. Who speaks for them? EGPAF is renowned to have done lots of programming for prevention and treatment of pediatric HIV/AIDS over the years. Dr. Mwangi, if a child was to speak, what will they ask of this summit on matters integration?
Yeah, thank you so much, my friend Dr. Sirengo. The child first say they are the forgotten lot. You even see I almost risked being forgotten when I was coming to represent the children, because children are the forgotten lot in this equation. We are still lagging behind because of that missing link. The adults, we are saying we have reached 98, 98, 94, 96. Children, we are still at 85, 85, 74. So the children we are still being left behind as children. And we really have to be very careful. How do we ensure that we intentionally remember children? I really am very happy that we have the chair of the parliamentary committee and your members here. The last time we met here about a year ago, we mentioned about having a pediatric parliamentary, caucus that will be there to deal with matters children. This has not as yet been operationalized, so the first request I will want to make in this forum, can we operationalize a pediatric parliamentary caucus so that we are able not to forget our children? The second one is the funding. Can we ring-fence funding for children? Traditionally, our children would be prioritized. They would be given food first. But now when you mix all the food together, the adults have taken the food for children. Can we ring-fence the funding for our children so that we are not only talking about the sheep, but we have money that is ring-fenced for our children? The third thing is really, when you talk about integration, we are really talking about the child-centered care, child-centered approach. How can we have a holistic approach for our children? How can we ensure that we are now able to not only address the HIV, but the immunization and everything? It requires a lot of intentional approach so that we ensure that we provide a holistic, child-friendly care, even as we think about all these integration. And finally, and most importantly, I am a very happy person today and being in Kenya because we have been in this war for 35 years saying we should end pediatric AIDS. But now the whole world has converged to say it is possible, and for Kenya we shall be able to end pediatric AIDS by 2027. And that's why I am advocating. Can you read what I'm saying? Can we have more people who are here ready to advocate that we end pediatric AIDS by 2027? No child should be born HIV positive. No child deserves to live with HIV. We should be able to end pediatric HIV. God bless you. Back to you. Thank you.
Thank you, Dr. Mwangi, and apologies for almost forgetting you. I'm sure we promise not to mix the food for the children. So, ladies and gentlemen, we have heard from the communities, we have heard from the children, the adults, and now the children. This group of clientele, they seek for services from county-owned health facilities, largely. And so, to help us understand whether this discussion of integration is going to go anywhere at the service delivery point, are two very important persons in the room, Dr. Wako and Dr. Lynn. But I'd like Lynn to start. You have been with us in this discussion. You know that we have lots of disparities in terms of service delivery scope, comprehensiveness, and quality across the different counties. As a spokesperson of the counties, from this summit deliberation, what is your proposed key components of the action plan to make integration work?
Thank you very much, Dr. Sirengo. I want to start by thanking Patricia and Rosemary for their comments, and Dr. Mwangi. And sorry that you are forgotten. I think one of the key things, in my presentation earlier this morning, I asked a question. As we think transition, as we think sustainability, are we thinking about our ability to absorb the shock of the gap? And Dr. Wangia spoke about it. But I want to thank them and at the same time allay their fears by giving them the Homa Bay experience. You heard me talk about over 1,000 staff that are supported by LVCT in our facilities. So one of the things that we've done as a county, and it's what I would encourage my colleagues in other counties to adopt, is to test the waters. What do I mean by this? So right now, these staff are supported by partners. but we've decided to integrate them and pass them through the payroll, through our County Public Service Board, to see if we added them to our staff component, what would our wage bill as the Department of Health look like? And we are doing this as one of the precursors to our transition journey. So right now we are seeing the shift, but we are thinking if we up our game and we are able to squeeze here and squeeze there, we are actually going to be able to absorb this component of partner HR, human resource in our facilities. At the same time, one of the reasons that I strongly advocate for this integration is to have that scenario. So it's easier to have bloodlines. What do I mean? So in my experience as a CEC, I would go to a facility and I call the staff. I've gone around, I stand somewhere and I call the staff. But I see there are 2, 3 CEOs and nurses who are just there at the corner. They're continuing to talk. And then I would ask the maid soup, why aren't those ones coming? And they say, oh, Waziri, those ones are not our staff. They're partner staff. I called Dr. Komo and said, I do not want to hear that nonsense of partner staff and our staff. There's no patient for Her Excellency Gladys Wanga and no patient for LVCT or PATH or whoever. It is the same patient. So that is when we had this conversation. And right now, it's working better. What do I mean? Because we understand the workload as one. And that, for me, is the main reason behind integration. When a patient comes to a facility, the patient could be HIV positive. She could also be pregnant. She could also be having malaria. Are you getting my point? So it's not possible to say, so you go for this here, and that you make the patient tired. So integration for me solves the problem of having bloodlines across service delivery in terms of he who pays the piper calls the tune. At the same time, I really do not envision a situation where we meaning me, Roslyn, as a CEC for Health for Homa Bay, who has been given that mandate by the governor, and speaking on behalf of my other 46 colleagues, that we let down our main responsibility, which is the responsibility of providing health services to our people in the 47 counties. And we hand over that responsibility to a partner. So for me, that is where integration works best. We are taking back our responsibility. We are giving agency to that which the people gave us the mandate to do, and saying this is how we are going to do it, and then inviting LVCT to help us, inviting PATH to help us. I really do not understand the scenario that we have been building in Kenya. And the example I give is when you're building a home in my part of the country, you call neighbors. So they help you to build the home, you cook for them food. But in our case, we called Brian to come and help us build a home. Then we went and sat under the mango tree. So Brian is now the one building the home, cooking food, doing everything. It is very un-African. Let us take back our responsibility to provide health services to our people. I am paid a salary purposely for that. Honorable Pukose here was elected specifically to speak for his people on that. So let us take back. For me, the next step, Dr. Sirengo, is we must take responsibility of what our government and our people, and to borrow the chairman's words, our taxpayers have given us the responsibility. How do we do this? We must unbundle all the institutional roles. We are here today talking about HIV. NSDCC is not here. I do not speak for the national government, so I do not want to talk about the issues that could be between NASCOP and NSDCC. But for us as counties, let me just tell you, sometimes it becomes tiring, Dr. Sirengo. What if next week now NSDCC has another meeting? I am supposed to leave my post and come back for another meeting. The honorable members are supposed to do the same. Could we at least have the Ministry of Health have a unified approach to some of these issues? So that we know, yes, NSDCC and NASCOP are in the same room, but your role stops here and your role starts here. It would help us to have one conversation. Lastly, we are talking about service delivery. But where are the counties? How many of my colleagues CECs are here? I see Makweni there. I see Kericho, I see Migori. We have few. If you combine the CECs and the CEOs, just by a show of hands, how many people are here from counties, not communities, county governments? Please put your hand up. These are the points of service delivery. These are the people, thank you, you may put your hands up. These are the people tasked with executing what we are discussing. But how few are we? How many are we in this room? We are having the right conversations with the wrong people. I'm not saying the other voices are not important, but at the front of service delivery must be the county government. And Dr. Afula is my very good friend, very, very good friend. But are we going to have a national government heavy? The national government that has how many referral facilities? Or are we going to talk to the counties who have over 16,000 facilities to deliver this service? We will speak this until the cows come home. The service delivery, as Patricia said, will never change because I did not listen, I did not make the commitment. So let us unbundle the institutional roles of every institution and give everybody what they are supposed to take home. Lastly, let us separate issues. I know we are talking about integration of services. Patricia, the issue of money will come. And I say this with confidence. I speak on behalf of Dr. Wangia, who together with, we chair the TTC, the Health Financing TTC of the CC's caucus. As Chair Pukose said, there's a lot that is work in progress. So do not feel very disgruntled that we are not going to take care of the number of visits you need per year. The one of the 25-year-old paying that one, I'm in that with you, but I'll not talk. I'm a public servant. I'm not supposed to play politics. But in terms of looking at the interest of our people, I do not think there's a law that can be passed in Parliament, and we have the honorable members of Parliament here, without considering the interest of the people. So maybe there are things that we missed in the initial, but I can assure you that that is going to be rectified. Lastly, I'm a bit disappointed that the Senate is not here. Health is a fully devolved function. The Senate is the one that speaks for counties. It is a pity that they are not here. I don't know if they were invited. I'm sure they were invited. I don't know why they are not here. But I think maybe through you, Chair, I'll pass the message. Could we just learn to serve the people of Kenya? Whether it is an issue that we do not agree with, bottom line, Wanjiko, Awino, Nafula, and hapa coast wanaitwaje? Fatuma, they just want one thing, service. There are some of us who have choices. I might have a choice that if I'm sick, I can even choose the facility I want to go to. But a lot of our people do not have that luxury. So whatever decisions we make, whatever choices we make, let's just remember that person who depends on that decision that you're making. Thank you.
Thank you, thank you. Thank you very much. Dr. Roslin, for your some powerful submissions. Before I invite Dr. Wako to speak, there's a critical question that was posed by Patricia. I was also keen to follow. With the new health reforms, the HIV patient is everywhere, from community to level 6. How do they utilize the funding, the funds that we've created, primary health care fund, the chronic and critical care and emergency fund, and the social health insurance fund? Dr. Wangia, are you online? How can you explain to persons living with HIV how those funds are going to work for their services?
So thank you so much, Dr. Sirengo, and I'll just pick up from Dr. Rose's submission during her remarks, where she said that when you are in medical school, you don't really learn about one condition. It's more or less integrated. So, and that's how I see it, that these HIV patients, apart from them having HIV, they are just a normal. They are a normal citizen who can have any other condition. So if they have a flu, if they have malaria, which is not complicated, they'll seek services at primary care level. If they need services, maybe they have non-communicable diseases, they'll be referred to level 4 to 6, and there they will be able to seek services at that level if they are paid up members. If in case they have renal failure or get a cancer of some sort, then they will also be catered for by both the social health insurance fund and the emergency fund. So just look at it as funds that can cater for this HIV patient, for the needs of the HIV patient. So the main thing that is supported, I know, by partners is the ARVs. For now, of course, that will continue probably for the next 2 years as we look at how we can slowly bring them back on board. But for any other service, they need counseling, they need health promotion, it will be given at the different levels. So they will take advantage of all the 3 funds.
Thank you, Dr. Wangia. Just like when you're on a train that is cross-border, it should be flawless. You should not know that now you're moving from Kenya into Uganda. What's most important is the destination. So we hope the systems will be seamless to serve the patient. So thank you very much.
Can she clarify that it is not true that she's only entitled to 4 services?
Okay, Daktari, there's one more question for you. The limitation of the visits to 4 per year, is that true?
So yes, indeed, and all this, when we do the actuarial analysis and look at the costing, it's usually based on data. If you look at a stable patient, even the stable HIV patients, especially the stable ones, most of them are even seen twice a year, especially when you think of the differentiated care. So any other approach will be handled on a case-by-case basis, but it's really usually important in any form of insurance to have some limits to deter whatever provider-induced or patient-induced behaviors. But if there is a need, say maybe someone is an unstable hypertensive, then there'll be that opportunity to have more frequent visits till they become stable. But you're saying if you are stable, then the 4 visits are maintained per year, so that you come, you are seen, you are reviewed, you are given your medicines, a prescription for 3 months, where you'll be refilling every month. Then after 3 months, of course, you are again seen, and probably a workup is done once again. So that is the reasoning behind the 4 visits.
Okay, Dr. Thank you. What I hear from you is that it's case by case, and the 4 visits are really for purposes of doing the maths. I hope it is like so. So to usher us in to the next line of speakers, I would like to invite Dr. Wako. Dr. Wako is one of us. He works for a very special program called Building Resilient and Sustainable Health Systems under the Global Fund. Dr. You've been here, you've listened. How do you propose that the framers of integration align to what you are doing?
Thank you very much, Dr. Sirengo. I wish I had a whole session to do a presentation with PowerPoint, because I really feel excited to do that. But given the 2 minutes, well, actually I'm in a very, very excitement mode right now, because what we are doing in the health system strengthening space is actually to look for those nuts and bolts. When the specific disease programs chase their conditions, the HIV, malaria, TB, NCDs, everyone chasing, as we look at what are the connecting issues, what is the connectedness, what kind of environment should these programs work on, and try to fix those, what I call non-medical aspects that will help optimize the utilization and achievement of these programs. Well, we have been looking at making sure that they achieve on their own, but now it's even becoming more exciting as they want to achieve together. the HIV program would want to achieve with the NCDs and others, in an integrated fashion. So it actually takes us to another level, and it's becoming very, very exciting for us in the health system strengthening space. So, as I said, this would be a whole lecture, but in a nutshell, what we look at are those non-medical system issues. For example, we look at what kind of financial sustainability mechanisms do these programs display and try to fix. We look at the reality, for example, when you look at the financial system, what is it about donor transition? What is it about domestic resource mobilization? We help them achieve that. What is it in terms of optimizing the available limited resources in terms of going innovation? For example, the enterprise resource, the M-Pesa platforms, and how do we migrate to the ICT space when you're managing finances? And then the reality of dwindling donor support. I like this strategic. I think Dr. Wafula Ross is a leader. Can you give her a clap? She's not just, I think she is a leader. When I look at this, Chairman Pukose, when I look at this is a very strategic movement. As the funding for HIV space, but realize that we are not talking of AIDS now. We only have HIV, isn't it? AIDS is quite something of the past. When we look at the funding landscape for HIV, it is slowly dwindling. But now we are strategically moving into the UHC space. Are you guys seeing that? So Patricia should actually settle as the government of the day is busy trying to, build the revenue base through collection of taxes, the social health insurance fund, the UHC, all this, from the exchequer, from contributions, there is money that is coming. So Patricia and our communities should not get worried at all. And HIV program is slowly going to dip into that instead of working in a silo. Isn't that beautiful? So there is future, there is hope ahead. So we look at that, we support the programs in that. There are many, those areas. We look at the human resource, for example. What kind of human resource for health are we displaying? We are talking of high quality, affordable, accessible, equitable, health, highest health standards. And what kind of human resource are we displaying? And we invest in that as RSSH through the support of the Global Fund. And everyone is coming. Actually, the World Bank is also coming to the building resilience. So that space, how do you ensure we have the requisite human resource? Despite the AIs, despite the technological advances, we still require, very, very sharp human resources, highly skilled, skills mixed and well-placed, deployed everywhere. So we support in that area. As we say, there is no commodity, no program. No program can claim existence if they do not have the requisite commodities. So we, as RSSH, also invest in making sure that there is, product selection, focus and quantification. There is visibility of those products from the central stores to the most peripheral facilities, that at the click of a button, we are able to see what is available in the facilities, what is available in the national stock reserve, for instance. We are looking at service delivery, the qualities, what kind of service delivery are we giving? And integration is one of those. It's one of those that now we are not looking at an HIV patient, we are looking at a patient who requires to have their blood pressure checked, their blood sugar checked, their malaria sorted, holistic approach. Very, very, very exciting. So we have all these approaches that look at what kind of other information do we invest in. Another big area is health management information system. That's where we help the programs to ensure that they collect, and use, very important, use the data to inform policies and change. I'm sure we are here courtesy of some information that was collected and found useful to bring us to Mombasa and discuss how do you guys feel if we integrate. And we have all agreed that we are going to integrate. That can only happen if we had, unless we had the data which have been shown. So there are so many areas, including leadership and governance, that we do under the resilient and sustainable systems for health, leadership and governance, and making sure everyone is on the table. When I talk of RSSH or health system strengthening, please always remember it is the formal and informal. Informal meaning community systems. Community systems are a major part. We work a lot with Patricia, and where is Oilia? Joshua, my young man? You're somewhere. Yeah, we work with him a lot to ensure that the community systems are also strengthened. So we have a resilient community that is receptive to our health interventions, and that they have information through community-led monitoring. They collect their own information, they collect and they use the information to make decisions. So,
okay, Dr. We need...
yeah, so thank you very much.
I agree, we need a whole day.
Yeah, thank you, Dr.
I am very sure the audience have very burning questions, so we also want to create some time for them. So kindly, if we can move on to my good friend Joseph. You were on this podium telling us how Equity Group, as a private player in the space of health, can partner with us. You have listened through, and now, in brief, what do you think are the key areas or opportunities for private-public partnerships for us to integrate?
Thank you very much, Dr. Sirengo. I think I'll start my conversation by giving you a story on COVID. When COVID came to Kenya, our GCO, Dr. James Mwangi, mobilized resources to develop PPEs to protect our healthcare workers. And we mobilized money in terms of billions, and they actually made those PPEs locally, supported the local manufacturers, and he went himself specifically to the facilities in the public sector giving those PPEs. Health workers, did you see him? Now, Dr. Sirengo, there goes one opportunity that the private sector can use that example of COVID, where funds were mobilized through the private sector. People put in money. And as a bank, we have the capacity to help bring the health sector, the education sector, the business people, the faith-based, and everyone in this country to speak about this integration of how do we deal with financing of these diseases that they have been a problem in this country and across Africa. Number two, if you look at what Equity has done as a bank, the economic transformation we have done over the years is a true testimony that given that opportunity to marshal the private sector, using and leveraging on the existing infrastructure, we are able to give landscape and the models we have used before to transform lives. I gave an example here when we started, and I said, even for young people who we are saying that they have no jobs, and they are living with HIV, and they need support, we really need to use the private sector in partnership with governments, partnership with faith-based organizations, partners, to make sure that we support them. And I remember talking about seed fund, Dr. Sirengo, and I said, if we put in our resources together, after marshalling everyone, all the stakeholders, and we put in a seed fund and say, how many are they? Are we able to fund even a pilot, maybe of 100, using the equity model and say, we give them this money, we train them, entrepreneurship, risk management, debt management, saving, and then we hold them and show them how business is done. And then within a period of 1 or 2 years, we can have a story to tell. Then the other thing is we can develop a co-funding model, which has structures, which can bring everyone on board, the development partners, the government, the private, and then we have a fund. And then we create a mechanism of how do we disburse these funds, and how do we foster accountability, and how do we make sure that we use low costs. And even when we are procuring, we don't exaggerate prices because we really want to succeed. So that is one of the things that is very important. Then the other one is financial literacy and entrepreneurship. As a bank, we have trained so many people in that area. One challenge we have in this country is that every time when a person comes to a financial institution to get a loan, they think that the bank is only interested in getting interest. But over the years, as a bank, we have also noted that majority of the loan defaulters are due to health issues. Somebody got a loan, became sick, and suddenly they can't be able to pay. So how do we support? And in this, we have done a lot of data, we have done a lot of project management, and we are helping our customers to deal with that issue. And we, as a team, Dr. Sirengo, you can bring in that and now plug it in. And then finally, does anyone cost, what is the actual cost of managing one patient per year of HIV or TB or malaria? And then once we do costing, as a private sector, we would be interested to know how much is that cost? And then we start asking ourselves, what is the pipeline of where this money is going to come from? How much money is coming from government? How much money is coming from development partners? How much money can the private sector put in? And then we put these funds and make sure that as we integrate, we don't leave anyone behind. Whether it is one person suffering from HIV in Mandera or 50 suffering in Siaya, they must all be considered because they are human beings in this country.
Thank you,
And
Dr.
then to my friend, Dr. Robert Pukose, we need political goodwill. We cannot move. This integration will not work if the political goodwill from the National Assembly, from the Senate, from the county assemblies of the county governments, if we don't involve them and let them have the political goodwill to support and even the budgets, it may be difficult, Dr. Sirengo, to move. So we need them. And I am very happy to see the chair here with his team. And I want this to be taken also to the county assemblies so that they can be able to help us.
Thank you, Dr. Sorry,
you.
I have to stop there. In the interest of time, very good submissions we are hearing. I hope our rapporteurs, you are capturing every single thing, including the comma and the full stop. Yes, now over to my good friend Brian Retchman. PEPFAR has been here for years, over 20 years, supporting Kenya in public health space. I know you have the figures, how much has been dispersed so far. But in the recent past, there have been conversations about sustainability, journey to self-reliance, increasing domestic resources, very nice words, you know. Now, you have listened in about this discourse for sustainability and integration. Going forward as PEPFAR, what have you learned from this summit that will inform how you design the next country operation plan to support Kenya to navigate through this? Thank you.
Thank you, and I think I'll start by continuing the analogy of building the house, because I think, you know, as PEPFAR first rolled out, it was very much an emergency program, and as it continued to evolve, we continued to build a house that was for a family of 13, that we continued to modernize and made sure that every room had a nice TV and everything, and what we wanted to do in this is really start a discussion around, okay, what is the house that you actually want? What is the house that you actually need? And I think that is one that really is we're starting to do for the first time. And it's really one that we want to make sure that we're doing with as many people as possible, and, you know, doing that bottom-up strategy as well. Thankfully, we've been doing that bottom-up strategy with our COPs for the last several years, and I think especially the last 2 years, As we've started to hear about the UHC strategy and PHC implementation, we were like, hey, there's a room for us right there, for us to be able to understand how to integrate better. And you know, it really has been evolving for the last 2 years. And I think last year's COP in particular, I would say COP review, because it wasn't a full COP, was one where we really sat down and said, okay, how can this work? And we started mapping out exactly how it would. And I think we started to talk to our partners about, okay, if you wanted to start doing some programs that would integrate, let's see what those look like. And really, from Rose's slide earlier to show in, I think it was 15 or 16 different counties, things are getting started and things are really moving, and I'm really super excited. And I think we have to recognize that the one size doesn't fit all, that an approach that works in Homa Bay may not work, and Turkana may not work in Nairobi. And so I think that really understanding what that looks like and trying to match it against the UHC strategy is going to be a little bit of artwork, but I think it is one that should be really exciting. I do want to point you might have heard we had this visit that went to Atlanta and DC a few weeks ago, where President Ruto came, and during it he signed the CS signed the guiding principles for the sustainability roadmap that we plan to put together by the end of the year. Of those, there were 7 guiding principles. 1 is building government institutions. 2 is using the PHC strategy to anchor transformation of the HIV program. 3 is aligning funding availability with the Social Health Authority. 4 is realizing the really enormous potential of regional manufacturing and local manufacturing, particularly Kenya, I think, is primed for it. 5 is leveraging digital health. And there's 6, not 7. Sorry, I miscounted, because I lettered them instead of numbered them. And so the 6th one is reviewing financial models to increase the way that we do things, potentially around adding government to government. And I think some of that's going to be at the county level, some of that will be at the national level. But I think using those 6 guiding principles, it'll really help us to understand how these things will fit together in the next COP and moving forward. And I think the other piece to the state visit that I am hopeful to get across is that it wasn't just about health, or it wasn't about specific, like these programs that are development focused. It was really about building the economic base of Kenya so that it can provide for itself in a much better way moving forward, creating more jobs and really creating a better space for manufacturing across the board. And I think that's something that our current ambassador has really helped to do in several counties and many counties. Yeah, especially Homa Bay. But I don't want to just say Homa Bay, because we've been in a lot of places, and I'm really hopeful that will not move Kenya not just into the middle income, but hopefully even farther, because I think that the possibility is there. And I think the last thing I will say, seeing Wangia's presentation, I'm very hopeful of that HIV integration within SHA. There's been a little bit of back and forth, and what we've heard from, especially from the PS, is that when he says universal health coverage, he means universal. And I'm starting to see that in the presentation, and that HIV is going to be integrated, but it's going to take a little bit of negotiation to understand how HIV is going to work in that. And so I think I look forward to those discussions in the next few years.
Thank you very much. We are going to appreciate our speakers in a special way after we finish, but we can clap for Brian. Now, you've had the discussion, you've had the submissions of the different speakers. Bottom line is that we need resources to do many of these nice things that we are proposing. We need resources to implement the action plan that is so going to come out of this. Dr. Bukose, you are the chair of the Health Committee of Parliament. You've had discussions since you came in. will you please share with us your insights in terms of what Parliament can do around issues of budgeting to enable Kenya transition smoothly from largely donor-dependent programming to sustainable programming?
Thank you, Dr. Sirengo. I think I want to also give the analogy that was given by Dr. Ross about building a house. I think that was brilliant. And as Kenyans, we must learn to build our own house. You know, the donor money that we depend on is taxes that are collected by other governments. They pay taxes in their countries. That money is collected and is given to you as a grant or as a loan. When the government, the current government came in, our budget deficit was around 900 billion. So we had to borrow money to fill in the deficit. With the last budget, that deficit has been cut down to 600 billion. And what the government is doing is working around the clock to see where else can we be able to seal, and especially there are areas that it's possible to seal. Among them, you can find that this government pays annually around 400 billion in terms of VAT claims. You collect taxes to pay for VAT claims. And some of those VAT claims are fraudulent. So the government must be able to come up with a law to seal some of those frauds that are happening. And that is some of the things that are within the current finance bill. We might be very happy moving outside there and saying reject, but this is where we are talking about domestic resource mobilization. How do you reject when you are being told to mobilize your own resources to do your own, to provide services for your people? And I think that is where the conversation should be. And we must be able to you give suggestions. What is the best way that we can do that resource mobilization? So for me, as where I sit, we expect that moving forward, as we continue sealing some of those loopholes for fraud and loss of public funds, we must also, as the president puts it, live within our means. And when we live within our means, what it means is that whatever we should be able to generate our own money and take care of our own other diseases, among them the HIV, and as we integrate with other diseases, how do we finance? So I think that is what Parliament do. And world over, Parliament is actually, one of its roles is to put taxes to its citizens and enable government to collect money. I know it is very bitter to some people, but you can look at it backwards and realize that for you, you are asking government, can we create employment? But where do you expect the government to get the money? You are telling government, we want this service. Where do you expect government to get that service? Counties, majority of you are from counties. They've been asking, increase the budget allocation to the counties. Where are you going to get the money? You will get the money from paying tax. And that is the bitter truth that we must accept as a people. I think that is how, that is my simple response to that.
Through the chair.
You know, Dr. Sirengo, my colleague, Honorable Salasia, the other day was saying, how come, and that is the question I've had some people ask, how come we cannot use the finance bill for last year? Every budget, has its finance bill. And even next year, you'll have a different finance bill. Last year, we had a different finance bill. Okay? And as I told you when I made my initial remarks, in the past, finance bill used to be a document that was just put inside there with other documents. It is read by the cabinet minister, by the minister, and then tabled, and it goes away. Tomorrow naamuka, bei ya mafuta imeenda juu, bei ya sigara imeenda juu, without you understanding. This is now when you now understand that, oh, kumbe this is how government raises money. But it's the world over, it does like that. Thank you, Dr. Sirengo.
Thank you very much. Can we clap for our speakers? You will be given an opportunity to ask a question. You are going to be given an opportunity to ask a question, and that's exactly where we are heading. So please prepare your question if you have it. I would like us to prepare our hands and appreciate our speakers at this point. I know I'm standing between you and lunch. Can we please appreciate our speakers? Makofi. One time, I was very angry with my father because he was telling me things that I needed to do that were not very pleasant. When I reflect back, I wish I would have listened more. That's a short story. Thank you. Now it's an opportunity for questions. We have an opportunity for questions, and we're just going to take 5 questions. Please, we can take one from that side. As we go this way, if we can have the roving mic. Quick questions, if there are any. We can start with health financing before we allow Dr. Wangia to drop off. Okay, I see one hand at the back. Any other hand? So let me give numbers. The lady at the back, you are number 1. The gentleman here, you are number 2. The young person there is number 3. And final question, one of you, not both of you, one of you. You are number 4. We are only taking those 4 questions. So number 1, please go.
Hi, good afternoon. My name is Wamboi Nyoike Salome from ICW Kenya. And this goes to our finance parliamentary man chair. We don't have a problem with taxes, but we have a problem with what is being taxed and who is being taxed. Honestly, I would put it that Kenya was, Kenya is, and Kenya will be. Please don't make it so difficult for us, the Wanjikos, the Aminas, the Fatumas, and the Kamandes. Don't make it so difficult for us such that we are already milked. So where are we making further? Secondly, can we get an account of where are we, is this money being accountability? We don't have a problem with taxes. Thank you.
Okay. Thank you very much for your question. Kindly ask only one question. Number 2. No. Please don't give it to someone whom I didn't give a number. Number 2. They know themselves. This gentleman here.
Thank you very much, Dr. Sirengo. My name is Dr. Kome Muduri from Meru County. And my question is what Dr. Joseph Bai was talking about on the issue of costing of healthcare. Has this been done already, or how best can we go about it? Can we have a team of the health economists put somewhere and tell us on average how much it costs to provide this care? Because at the end of the day, Dr. Pukoso will ask, how much do you need? We need to have that answer. Thank you.
Thank you very much. Dr. Wangia, I hope you're still there. That's your question. Number 3, Mr. Kerry.
Good afternoon. Yes. My question comes from a statement Mheshimiwa has just made. He said something about live within your means. Currently, as a youth or as somebody who is not formally employed, it's very difficult for me to be able to already access health services. And not just health services, but quality health services. And we find ourselves where we're in a position where our parents or the people who we depend on are taxed so that these services are offered to us. Now, if I am not able to sustain myself, and you are talking about taxing the people so that the government is funded, but we have, and you've told us to live within our means, but our leaders are not practicing the same. Because from the budget, you will see, from the budget, you will definitely see that somebody has been allocated 600 million for a house that was given 400 million, but leaders are not talking about that. Leaders are not talking about Treasury being given, I don't know how many billions for tea. State House currently from the new budget will spend 3.8 million on tea a day. So, because if you're telling me to live within my means, but you leaders are not practicing what you preach, how is it that I, as a youth, am supposed to believe in you leaders? So in terms of living within my means, I just need you to explain to me, living within my means, my take home, if I'm earning a salary of 50,000, my take home is 24,000 shillings. So tell me exactly, how will 24,000 shillings be able to finance my health, the health of my dependents, because that is within my means.
Thank you very much. Please, I would like to remind us that this is not a public participation for finance bill. But we hear you. There was a number 4 somewhere. There was a question number 4. Yes, please. Please do not repeat any questions that have been asked.
Mine is not a question, but my name is Damaris Juma. I come from Tongaren, and I work directly with teenage mothers in my community. Chair, there's a case that we were dealing with last week. Teenage mother went to deliver at a nearest hospital, our local hospital. She went to deliver, but she was asked to buy the gloves, everything that is required by the medical provider so that she can be attended to. And I understand, like, they've said we should not talk about healthcare financing, but these are people, the people in my community are very vulnerable, and sometimes they can't even afford those things so that they can be served or to give birth. So there was a program, the Beyond Zero program, that we are currently seeing it's not been allocated anything. I don't know what the health department can do to support the mothers to those mortalities that can be prevented, and so that they cannot even get infections during birth. Thank you so much.
Thank you very much. I will stop there with the questions and allow the panel to respond. I would like to start with Dr. Wangia, if you are on, if you can answer the question of costing, and then we'll allow you to go. Do we still have Dr. Wangia online?
Yeah, so thank you so much, Session Chair. And indeed, costing is one of the things that we do. As we speak, we at least have managed to do the costing for primary level services. Costing work for HIV is also ongoing. We have what you call the activity-based costing process. So slowly by slowly, we'll build up that database, because if you think of the interventions, we have over 5,000 interventions. And as you go higher, the interventions become even more complex. So our intention is to work closely with even the associations, medical associations, so that they can request their members to assist us in costing, because they are the ones who know the inputs for different interventions. So yes, we are aware of that, and we are prioritizing that as we move ahead. But it's not a one-off process. It's a process that can last maybe a year or two. So thank you so much.
Thank you, Daktari, and thank you for your time. You are now free to log out. Many of these questions are directed at Dr. Robert. So we will allow you to respond, and we stop questions at that point. Thank you.
Thank you,
Maybe
Dr.
maybe you come
I
here.
need to stand. Thank you, Dr. Sirengo. What I would want to say is that my firstborn son was born 2000. The second one, 2003. So this group calling themselves Gen Z are my children. Okay? And when you are in the house, you have to provide for this group and any other person who is there. It's our responsibility. But we must also teach you the correct things to do. We must also inculcate in you responsibility and tell you the truth. When we travel outside Kenya, you'll find that when you go to even a town, you'll be charged a town, they call it city tax. Anybody who has traveled outside this country, you'll find in your receipt there is a city tax for just being in that city. We've moved from a state where, as a country, our healthcare was, sometimes when some of us were growing, our healthcare was completely funded by government. Then Mwai Kibaki came in, introduced FIF. Then we started paying for something. Then we transitioned now into county governments. County governments struggle to be able to meet those obligations. A challenge is not easy. Because I've worked in a county. My teacher, Professor Nduat here, taught me. I think Professor Kimayo was also here. He also taught me. I've worked in the county as a medical officer, as an MOH, and as a medical superintendent. So I know the challenges that happens within that place. And we're now moving into a state where initially we had a lot of donor funding supporting our healthcare system. Now we are moving, donors are moving out. Do we allow our health system to collapse? We can't. As responsible citizens, we must look for ways of how we can be able to make sure that we move in, and that is where taxation comes in. I know there are people, there might be cases here where maybe you think leaders are spending as extravagant, they are spending money. Hold us accountable. Yeah? Hold us accountable for those areas where you think money is being spent wrongly. Let's have that discussion around where taxes are being lost, where looting is happening, and it happens either at the county government or at the national government, where people are stealing money. Let's have that kind of discussion, but with facts. We have institutions, EACC and others, which should be able to be able to take care of that. But for us as a country, and as responsible leaders, we must be able to accept to take our own responsibility and build our own country. As a leader, I would not want to leave this country to my children where they are not able to sustain it. And I think that is where the conversation should be. We are listening to you, but you must also listen to us so that we can have a healthy conversation. Yeah? Because when even now as people demonstrate in the streets, next week we are having committee of the whole house. My challenge to you, how many amendments have you made that you've given to your leader, your member of parliament? Which one? I can ask you, for example, you are shouting a lot. Which amendment have you done? You can't do that. That is being irresponsible.
That is being irresponsible. How can you say reject the bill when that bill is the one that is going to finance you to get the budget to give you money to provide health services, to employ the 20,000 teachers who are doing internship now? We want to employ the 20,000 who are doing internship and others who have now finished, another 20,000 to be able to go into internship. You say scrap it. So what happens to those ones? No, that is being very responsible. Yeah? And to me, my request to everybody is let's take responsibility. Let's reason as a country. I think that answers. I don't want to leave the issue that has been raised by the lady from Tongareni about the Beyond Zero program. It is actually funded. The Beyond Zero program has a fund so that it can still continue. It is funded. It has a budget line.
Thank you very much. Can we clap for our presenters? No. This is, please don't reject my clap. Can we please prepare and we give a good 3 factorial clap for our presenters? Can we prepare? Okay, we start. Thank you so much. Thank you, speakers. We appreciate your contributions. At this point, as we close, I would like to request Dr. Ross to come and lead us through the next session. As we close, I think it's going to take us a very short time to do that. Makofi yetu iko wapi as participants? Na yangu? Okay, Kayamba muko. Tengeneza kitu. Prepare some tune, please. Yeah, we can invite them.
Thank you so much, panel. Kayamba, please. That was a very powerful panel. Now I know why people need special skills to be in certain positions. Chair. Very honored to be in your sitting and just having the dialogue. Kayamba, please.
Shombode inamukanga Shibera Shombode inamukanga Shibera Muhanani hadu wa genyanga Kuri shombo sungusa marida Nishibera Shombode inamukanga Shibera Shombode inamukanga Shibera Hey Duhani hadu wa genyanga Kuri shombo sungusa marida Nishibera Namawa kawatola hunjira Namawa kawatola hunjira Namawa kawatola hunjira Namawa kawatola hunjira
Thank you so much. Thank you so much. Thank you. So the next session is going to be short. It's a closing ceremony. We have some recognition and awards. Quickly, I would like us to sit. Some of you are going to be awarded, and then you'll say we did not hear. I would like to invite Dr. Okomo and Mr. Rukaria to take us through, just calling up front the recipients and the categories that they have won, and then we have a close-up. Yes, Mr. Rukaria, proceed.
Thanks a lot, Madam Dr. Rose Wafula for this one. I know as Dr. Sirengo was rightly putting it, my standing here, every second I take, I stand in between us, and I'm including myself because the family is down there and demanding for lunch. So we shall make it very fast. Please, when you hear your name or the name of your organization, assist us to have it very fast. Come over. We shall award you, and then you take a seat. Then we have the next lot. Yeah, we shall start off with the institutions. The best performing county HIV, key and vulnerable population programming. And you can guess which one. It's Kisumu City, Kisumu County. Please, Kisumu, come over. Yeah. I will ask Dr. Luz to be ready to issue the award to Kisumu. Okay. The next one is best performing county in HIV positive identification or population. And guess which county is that? That's Murang'a County. Murang'a County. I'll ask Dr. Wako to be ready to award. Murang'a County. Dr. Wako? Okay, Dr. Rose, you can give them. Okay, thank you. Next, we are going to the best performing technical working, the regional technical working group in HIV, and this one goes to Nyawest, RTWG, Nyawest. Nyawest, come in front, please. Nyawest. The best performing RTGW. And for that, we are requesting Professor Duarte. Professor Duarte, please come and have the honor to award to them. Come over here so that a photo is taken. Please come over to the round carpet. Prof. Okay, Prof, my very good friend here, Dr. Ali, is looking for the certificate. Shake their hand, we shall make it available to them at the right time. As Nyawest is being awarded, please allow me to request also best partner support towards advanced HIV disease care. And guess what? That goes to CHAI. That goes to CHAI. CHAI stands for the Clinton Health Access Initiative. CHAI. Where is CHAI? Please come over. CHAI. And for CHAI, it will be awarded by Bowen. Okay, I'm informed CHAI, they are not here. Now we go to the big teams in town. Achievement 95 to 95 to 95 units target. Achievement 95 to 95 units targets, and this goes to a number of counties. We start with the Nairobi County. Nairobi County, cheer up. Be coming, please. Okay, I'm informed they are arranged in a certain format. Homa Bay County, please be coming up. Kitui County, please be coming up. Kirinyaga County, please be coming up. CDC, Garissa County, Laikipia County, Homa Bay County again, Kilifi County, Migori County, Kisii County, Kirinyaga County, Nyeri County, Kiambu County, Nairobi County, Kisumu County, Migori County, Turkana County, Kisumu County, Homa Bay County, Siaya County, Mandela County, Baringo County, Kisumu County, Nyandaro County, Busia County, Mombasa County, Siaya County, Bungoma County, Nyamira County, Kakamega County, Tharaka Nithi County, Makueni County, Machakos County, we would request the chairman to come forward. We would request the chairman parliamentary committee, Dr. Pukose, please come over and take a photo with the team. These are our counties.
They're all disorganized.
Ready.
Partners. Professor Kimai. These are individuals.
Thank you, Bwana DJ. Thank you, Bwana DJ. Thank you. Thank you, Bwana DJ. Thank you. Allow me now to go to the category of individuals. And we have individuals who are outstanding. Let me start with the HIV Service Delivery Integration Summit, Ministry of Health Republic, award to Dr. Martin Sirengo. Dr. Martin Sirengo. We are awarding Dr. Martin Sirengo because of special recognition as the pioneer advocate for HIV and chronic diseases convergence in Kenya. Daktari, karibu sana. I'm requesting Chairman of Parliamentary Committee once again, please Chairman, Parliamentary Committee, Dr. Pukose, come and award Dr. Sirengo. Cameraman, please take that photo of the season. And as Dr. Sirengo is being awarded, please allow me to request Professor Ruth Duarte to be upcoming. She is being awarded as the relentless advocate for elimination of mother-to-child transmission of HIV. Professor, welcome. And the professor will also be awarded by the chairman, Dr. Kose. Karibu sana, Professor. And finally, members, as you remember, I said I stand in between the gap of the food and the opportunity to survive. I will request you allow me to call the best or the relentless advocate for HIV treatment access, and this is none other than Patricia Ozel. Patricia, please come forward and be awarded by our chair. Patricia is an advocate on treatment access, and I believe we can remember how much she advocated for that. I better clap for her. Congrats, Madam Patricia. And with those few remarks, allow me to request the chair to take the seat so that we can be taken by our MC to the next level. One MC.
Yeah, thank you very much, SA. And I want to finally invite Dr. Rose Wafula to give us now the wrap-up as we close.
Thank you so much. I know a lot of us are wondering, what are the other certificates? We had other categories, but the certificates are going to be given to the counties, because mostly we're counties and partners, for their support. In the interest of time, we haven't called everyone and due to break, but we have categories around the innovations that we saw. So each innovator has their certificate, appreciating your effort. The planning team, you have your certificates. The Cabinet Secretary appreciates your thinking and doing this, so the certificates are there. So tulieni, tukitoka lunch, you'll come and pick your certificates. We also want to appreciate the partners who supported this initiative, including PEPFAR, Global Fund, Roche, Equity, Patek, Trinity, and Biosensor. They are their certificates of appreciation. It is no means fit for them to have supported within a short time. We appreciate. I know there are individuals also that have been called out, including BLAST, NEFAC, AMREF, Kenya Red Cross, for working with the communities very well, and AHF. So you have your certificates here, and we pray that you allow us not to go through the lengthy process because of time. Now, the last session is really closing, which is what next after this. It's just a few minutes, then we're able to close the meeting. Dr. Newton, kindly join me because you're going to do a vote of thanks. As Roslyn was speaking, she said service delivery is their mandate. You heard her. It's their mandate, and therefore, literally what NASCOP did was to listen to the counties and provide a platform for them to talk. They have been reaching out. People have been asking, which way? So we did what is our mandate, to coordinate. So in terms of stakeholder roles in health, Roslyn, I'm just doing my mandate as head NASCOP, and I hope there's no confusion. I hope you'll not have another service delivery integration call, because there's only one health sector and one NASCOP. But on a serious note, I think we have had a wonderful 4 days. We have learned a lot, and I would like to say that whatever she's going to share as critical next steps are things that we have agreed together with her. We have a secretariat that has been working on a clarion call. It's a one-pager. You will be able to receive it. It's a simple summary of what we've been agreeing. So Roslyn, I would like to call upon you to just share what we've agreed as the next steps moving forward in collaboration. Karibu.
Thank you, Rose, the Chair of the Parliamentary Committee on Health, colleagues. Mine is going to be very brief. We've had 4 days of deliberations, and as Rose has put it very well, what next? So what next is we've agreed, the 2 levels of government, that we are going to have a technical working group to handle integration, transition, and sustainability. Why do we want to have a technical working group? Because there are so many efforts being made all over. We might end up with confusion. I know the story of Kirinyaga is different from the story of Homa Bay and Migori, but at least we should be able to have a plan. And what we want is therefore that the technical working group comes up with a framework for planning, for national planning, give us scope, an operational definition of what transition and sustainability should actually look like, so that we do not have each one of us our individual understanding or interpretation of the same. In the same way, we'll come up with a toolkit. Now, I want to be very, very specific and very clear on this matter of the toolkit. The toolkit will be descriptive, not prescriptive. So we will describe, this is where we are, this is what we want to see, and this is how we are getting there. And then each one of us will be able to loop into that and pick their own individual way of doing it, but using the toolkit as a guide. We want to loop into the primary healthcare strategy so that all is not lost. I keep saying, and I have to declare that I had the advantage of working in Parliament for 5 years. I worked in the Senate. There is no law that does not seek to cure a mischief. So the UHC laws sought to cure a mischief. Let's ride on that in every aspect of health and look at that as our superhighway. And that's why I think we need to really plug into the primary healthcare strategy to deliver this transition and sustainability. If we are to do this, we must deliver as one. First, as a country, as a nation, and then as 47 counties. And that's why we need one roadmap. We will leverage on the investments that have been done on the AIDS investment so that we are able to come up with clarity. Someone asked about costing. All these issues need to be addressed by this framework. We'll also be able, the technical working group will be able to map all ongoing dialogues everywhere. And I think, Rose, probably that's what I was alluding to in my remarks, that we want to capture all the ongoing dialogues about transition and sustainability. Service delivery is hinged on very many things. There's human resource, there's domestic resource mobilization, and so on. We must map all these dialogues and bring them to the same table and have every conversation that's alive on the subject in one place and on every front. Next and last, the technical working group should be able to provide us with the new frontier, the next frontier. What will it look like? What are the issues that Patricia and Rosemary were worried about? How are they going to be addressed, and how will it look? So our suggestion, our joint proposal, that's the 2 levels of government, is that this technical working group has CECs, representatives, academia, national government representative, and I think anybody else who we will feel needs to be part of this conversation. Rose, as we agreed, time is of essence. So I think in the next, on behalf of the CEC's caucus and the Council of Governors, I want to promise that we shall be submitting to you names in the next 1 week. We have an intergovernmental forum on health next week. Dr. Sirengo, as we requested, we hope that this agenda can find its way into the IGF so that it is well discussed and it's well, the conversation, we find a way out and we find a proper solution. I want to thank you.
Thank you. That's the joint consensus. In the spirit of intergovernmental collaboration, I think, Roslyn, you've articulated it well. From our end, we have a secretariat, as mentioned. They will share the summit resolution so that as we go to the intergovernmental forum, we have had input. So we look forward to the input in refining that as one of the things that will be moving forward. As a program, we definitely would have to refer and communicate this to the leadership, and you look forward, Roslyn, to the names of that technical working group to consolidate this effort. Thank you so much. I want to invite Dr. Newton. He's been chairing the planning team. So all along, I know you've been seeing him move around with the milk cards. This guy has worked so hard. He deserves a clap. He has done an amazing job planning within a very short time. I would like to invite him to say 1 or 2 words as he gives a vote of thanks, and we then can close. Karibu Newton, and well done. I'm proud of you.
Okay. The Parliamentary Committee on Health, honorable members of Parliament, the Ministry of Health officials, the counties represented here, communities, civil society, partners, private sector, FBO, all protocols observed. Good afternoon. On behalf of the Summit Organizing Committee and NASCOP, I'm honored to deliver the vote of thanks for this year's NASCOP Summit. As you are told, this is the first of a kind, and would like to do this on a yearly basis. I want to give profound gratitude to our distinguished speakers and panelists. Your invaluable insights and expertise have greatly enriched our discussions and deepened our understanding of the crucial issues surrounding the HIV/AIDS integration discussion. We have sponsors and partners. We'd like to appreciate them. We are grateful. They were very generous in their support. And I want to say that we'll not leave this hotel with any debt. We are fully covered for the conference. Thank you very much. The attendees, the delegates attending this conference, your active participation, your engagement and contributions have been pivotal in making the summit a vibrant platform for the exchange of ideas and learning. We had an organizing team that worked really hard. Maybe let me just go, because we were a team, let me just go to the subcommittees that were here. So we had, I mean, it's good to mention some soldiers behind the general, and our general in NASCOP is Dr. Rose Wafula, but we had some soldiers behind, and they really made this work. I think we planned this in less than a month, and we have a summit of at least 500 participants. Dr. Rose Wafula for the overall leadership, Dr. Grace Rabut. Dr. Grace Rabut, just for the technical coordination, Dr. Ruth Kapanga. Dr. Ruth Kapanga, she was responsible for the county documentation and just organizing the counties in the summit committee. We had myself, we had Dr. Jonah Onensha. Jonah. We had our communications specialist, Rhoda Nisa. Rhoda, she's the reason we have all these screens here and all the pamphlets and IEC materials. We have Patricia Acero and Bernard Baridi representing the, Patricia is famous, representing the adult community, and Bernard Baridi, or his representative, representing Gen Z. Yeah, Bernard. Where is Bernard? Somebody do this for Bernard and the blast team. Then we have county representatives in the summit preparation committee, two very important people that really were part and parcel of the process. That is George Mochama and Dixon, George? Yes, and Dixon. We had administrative support from Mr. Bitok and team. He was bereaved. We had the session rapporteurs and various partners who were part and parcel. And I'll single out Dr. Evelyn Gugi, who was also the member representing PEPFAR. Thank you very much. And last but not least, I would like to thank NASCOP for, and NASCOP, we are looking at Dr. Rose Wafula for the leadership and vision. This was to bring together, to break the barriers. We want to integrate horizontally so that we are talking about, we are not talking about HIV in its own space. We want to go horizontal. Thank you very much. And on this, please have a safe journey back home. And we are praying that you reach home safely. And God bless you. Good day. Thank you.
Thank you very much. And kindly let's all be upstanding for the national anthem.
Mugeni akenda gane Kongo edwa Kongo mugeni. Kongo mugeni. Kongo mugeni. Kongo mugeni.